but I can speak to at least one other study that our MPN group here is engaged in, and that's the high-risk population for whom there is a dearth of management at the moment. Those patients in what we call accelerated phase, the myelofibrosis patients whose blast counts are creeping up. And so we don't make a diagnosis of blast phase MPN until the blast count is in excess of 20%. But once you start to see the blasts in the peripheral circulation, meaning something more than 1%, 2%, and once you start to see 5 or 6%, it's a bit of a uncomfortable situation, because you know what's coming, or you anticipate that in a 6-month period, if unmitigated, there is a likelihood that these patients will progress to a high mortality MPN blast phase, and yet there are no therapeutic interventions in that specific space. So many patients are just kind of awaiting demise. And so many of these patients are MPN MDS overlap syndromes, and there's a possibility of using what's approved for treatment in MDS, perhaps in this population. And we've collected a series of more than a dozen patients that we treated with oral decitabine. Decitabine is an older agent that's been around in the parenteral administration formulation, but the oral decitabine that was more recently approved really allows those patients to continue while they're feeling well in the outpatient setting, and perhaps push off this demise by some time. And we found in our dozen plus patients that there is activity in this space. It's of course not a controlled trial, it's a single center, it's very small, but the proof of principle is there that using oral decitabine may be a possibility in a patient population where there is currently a dearth of other therapies to push off inevitable demise.